Welcome to episode 5 of the Madness and Grace podcast. Today, Matt and I are joined by Dr. Michael Lyles. Dr. Lyles, how are you doing today?
Oh, I'm just fine. I'm so happy to be here.
Yeah, absolutely. Hello, Emily. You doing okay today?
Yeah, how are you?
I'm doing well. I'm very excited about this conversation today. So let me introduce our guest, Michael Lyles. He completed his undergraduate and medical school studies at the University of Michigan. He also completed a psychiatry residency at the Duke University of Medicine, where he was an American Psychiatric Association and National Institutes of Mental Health Minority Fellow and North Carolina Neuropsychiatric Association Resident of the Year. He was at one time an assistant professor of psychiatry at the University of Kentucky. And while there, he was awarded the Kentucky Colonel Award by the governor of Kentucky for advocacy work on mental illness in Eastern Kentucky. He entered the private psychiatric practice in Atlanta in 1986. Since that time, he's held medical leadership positions in inpatient, outpatient, and partial hospitalization programs for psychiatric and addictive behaviors. He is someone that I've known for a long time. And as I was saying earlier to both of you, when I was thinking about things that we would talk about on this podcast around questions I've been asked and concerns or kind of issues that people have about getting mental health treatment, medication has always been one of the biggest things. And I could think of no better person to talk about medication than Dr. Michael Lyles. Michael, thank you for being with us today.
Oh, my pleasure. My pleasure.
Dr. Lyles, the first question we had for you is what led you to become a mental health provider in the first place?
I had thought about becoming a pastor when I was a teenager after I had made a religious commitment when I was 14, but was led to go to medical school instead. And when I interviewed and one of the reasons I thought about being a pastor is because I grew up in a community around a lot of people who had tremendous emotional needs, and I was wanting to address those spiritually. When I interviewed for medical school, I could not spell psychiatry properly. I knew nothing about it, and but told them I wanted to be a missionary and deliver medical services to people in an underserved community. Not realizing that my third year of medical school, I began to realize that psychiatry might be a place God was calling me to serve, and that the Christian community was an underserved community when it comes to mental health needs. And through a number of things that I won't go into, including meeting Frank Minner, ended up going into psychiatry to be a medical missionary in the psychiatric world with Christians.
It's always interesting to see how God kind of moves us. We think we know where we're going, and he kind of moves us around where he needs us to be. So, talking about it going into psychiatry, one of the things that I find when I am engaging people that are looking for mental health services is there's tremendous confusion in their minds of what different providers do. Or there's this kind of, like, for instance, I have a PhD, which I'm a psychologist. You have an MD, you're a psychiatrist. What's the difference between what you do or I do or a psychotherapist or whoever? And so I was wondering if maybe you could describe kind of the role of the psychiatrist in the treatment of someone with a mental health problem.
The thing about it, I went to medical school to go into internal medicine and spent most of my medical school training focusing on becoming an internist. Like I said, it was the end of my third year of medical school. It's only 4 years that I decided to go into psychiatry. So I spent 3 out of 4 years preparing to do something totally different. But that was actually wonderful, because what a psychiatrist does is takes a look at the behavior and problems that a person is having emotionally and try to make sense out of, is this something psychological? Is this something, as a Christian, spiritual? Is this something medical? For example, I saw somebody today who had a horrible depression after having COVID. We know that was because of having COVID, but that's because as a psychiatrist, we study the medical aspects of behavior, the neurological aspects of behavior, and in contrast to someone who has a PhD like you, who's become an expert on therapy and assessment issues of someone without the medical training, or someone with a master's degree, a therapist who's more skilled at delivering the therapeutic resources for someone. A psychiatrist, when I trained, I'm very old. When I trained 40 years ago, as she introduced me, I felt even older. They actually did train us to become therapists. Now, the people coming out now wouldn't be able to spell therapy because they're trained in very exotic medical and neurological treatments and assessment. So the value, the uniqueness of a psychiatrist is, if they're doing their job as an MD, to take a look at a behavior change and assess whether there's a medical etiology or a neurological etiology to it that medication or some somatic intervention would help.
Right. And do you find typically it beneficial for your patients to receive both psychiatric treatment from you and also see a therapist for a talking therapy?
For the vast majority of people, that is the way to go. Because even, let's think about it. This person I saw this morning who had a horrible psychotic episode after having COVID. Yes, I was able to diagnose that, yes, that's what it was, and these are the treatments we needed to get you back. But this person has all this residue in their life of embarrassment and trauma that has happened because of what happened. They need to talk about it. She has questions about, why did God let this happen to me? There's a spiritual input to it. Her brother and her mother are looking at her differently now. They need help. So the vast majority of my patients, even if they have a really clear-cut medical etiology, need both.
Right, absolutely. And, just to kind of give our listeners kind of a demarcation in when training changed, what you find is that most psychiatrists that were trained prior to 1980 were actually trained to do therapy and give medication, pharmacotherapy. And after 1980, this huge growth in psychiatric medications has led the training to change so much to where it's much more kind of neuroscience, pharmacology. It's much more in that direction. And there really just isn't time for that training anymore in those individuals. So they're a real different type of, really a pharmacotherapist. It's kind of, a person who treats with medication. And so it's just a different way of thinking about it. Certainly very beneficial. And now that we're kind of on that topic of medication, finding the right medication, as you talked about, trying to find that medical etiology of what's going on there, or a mix of medications, that can take time. And I think a lot of times, particularly in this kind of fast-paced society we live in, we want that quick fix, magic bullet, fix me by Monday so I can get back to work and everything will be great. Can you give our listeners kind of a sense of what that process looks like for you and a client to try to kind of figure out what that right medication, the right dose, the right mix, what does that look like, and what kind of time frame are we typically looking at?
My daughter is a high school French teacher, and she teaches English speakers how to speak French. And what I feel like as a psychiatrist is someone that's doing a language translation, because my patients come in and they tell me their story, i.e. their symptoms. And my job as a psychiatrist is to take their symptoms and correlate it with what part of the brain would explain these symptoms, which neurotransmitter system in the brain is usually associated with problems with these symptoms. And so I'm taking their symptoms, translating it into brain language, if you will, and trying to correlate that with, is there a known disease entity or syndrome that we know of that might explain this? Or could it be a side effect of a medicine they're taking, or a drug interaction with medicine they're taking, or because of a medical problem they're taking? And, a lot of my focus is on the neurological, psychiatric, medical aspects of how we would explain their problems. And then with that assessment, come up with a treatment plan that tries to correct that. A lot of times that's based on their story. We may use lab testing, blood work, to try to get more guidance about that. We might use psychological testing to get more guidance about that confirmation. We may use genetic testing to determine if there's evidence of how they might metabolize a treatment. And then we put them on a medication profile, if appropriate, and that can take anywhere from 2 to 6 weeks for something like that to work. It's not an instant thing in most cases. So it is a time involved, and usually from the moment of beginning to the moment the person is well, say with depression, you're talking about, if you get it right the first time, 4 to 6 weeks before the person is getting back to the way they were before they got ill.
Do you typically find that when people are also getting a psychotherapeutic intervention, a talking therapy intervention, that you tend to prescribe them less medication, or that it's maybe easier to deal with the medication? How do you see those two going together?
If someone, because I'm gonna tell you, most of the time, even if we're able to come to some deduction about a medical or psychiatric etiology for their problems, there are a lot of other things going on that influence that in their life. And if they're doing the talk therapy, they tend to need less medication and get better quicker. And the vast majority of my patients, the first thing out of their mouth is, if I have to take a medication, I don't want to take it forever. What's the least amount of time I can take this medication? Am I going to get addicted to it? Is it going to change my personality? And the bottom line is, for most situations, there's a time period that they have to take the medicine for. And I tell them, let's not cheat that. Let's do that. And then if you do the therapy, that time period may be less. You come off the medicine soon, and you have a better prognosis for not needing to go back on something if we do it right the first time.
You mentioned just a minute ago people coming in and saying, well, I don't want to be on a medication forever. And a lot of times, we'll have a client come to the clinic who clearly has a mental health problem, that it has a very heavy neurobiological aspect to it, schizophrenia, bipolar, where we know that medication is going to be a part of that treatment. And they immediately say, I just want you to know I'm not taking medication. I'm here to get treatment, but I'm not taking medication. So could you give us some sense of the types of kind of concerns that you hear from clients about taking medication, or that, that hesitancy? What would you say to a person or family that was hesitant to be involved with psychiatric treatment?
A friend of mine, one of the problems of getting older is that you go to funerals more often. And I went to a funeral this past Saturday of the wife of a friend of mine. I'm at a funeral, okay? And as I'm leaving, this woman I know came up to me. Her son has bipolar disorder. And she goes, Dr. Lyles, my son has said he wants to stop taking his medicine and wants to know if you could give him advice on how to stop taking his medicine. He's been hospitalized 3 times when he stopped taking his medication. And I told her, I said, first of all, he has a chronic problem. This is not something you stop taking medicine for, because he needs it long term, like blood pressure medicine and diabetes medicine. But people don't want to take medicine because they think it means that there's something wrong with them spiritually. They have to take medication, that they're going to get addicted to it. It's going to change their personality. People will think less of them. I had a patient that led a Bible study, a women's Bible study, and she didn't want the ladies to know that she was taking an antidepressant because they wouldn't let her lead the Bible study. I encouraged her to come clean with them, and when she did, out of 40 women in her Bible study, 8 of them were taking an antidepressant and dealing with depression. It actually led to her ministry being better. What I tell people is that Jesus never healed anybody the same way twice. There's a lot of ways that people get healed. In the Old Testament, Naaman came to Elisha wanting to get healed in 2 Kings and said, I heard all these big miracles you've done. I want the big thing. And he told him to do something very mundane. And he got upset and said, I'm not going to wash in a river. I mean, that's just boring. I mean, I want the big splash. And a lot of Christians that way, they say, I don't want to take medication, even if it's working, because I'm supposed to get healed miraculously. And everybody know it, like they do on TV. And that's, God reserves the right to heal people the way he wants to. And sometimes it's something like Paul telling Timothy to drink some wine for his stomach, which was the recommended treatment for stomach problems in that time.
I read an article a couple weeks ago, and the title of the article was, Sometimes God's Healing Providence Looks Like Prozac. And I just thought that was just such a great title, because it was written by a woman, and she just spot on got it. She basically said what you just said, and that is, these are, good things come from the Lord, and God has equipped individuals to develop these things, and there's nothing wrong with that. And, Hezekiah gets healed with a poultice of figs, and there's all kinds of physical remedies in the scriptures. Why would we move away from that? And, I see that, and I'm sure you see this too. I don't know if you want to comment on this. I see it, there's a difference in when clients don't want to take medication. I mean, sometimes with our more seriously ill clients, they're not fully aware of how ill they are, or they have kind of delusional ideas around medications or paranoia about being poisoned or something. And I understand that more than I do the family that says something along the lines of, well, we don't want to take medication because, we just believe that God will heal him, or we don't want him to take medication because then, that shows he isn't really trying hard enough to kind of move beyond this. And those are the things where I don't get it, because really what you're saying is my loved one is ill and I'd rather they suffer through this without the remedies that exist. There's a weird self-righteousness in that, or something, in the sense that, like, well, I'm not that way. We just kind of work hard and we aren't that way. What do you've mentioned spirituality very often here, and the idea of faith in the context of this, as a person of faith and a psychiatrist, what would you say to the family or the individual who said, I don't want to take medication because, like I said, I had a client, literally his Bible study teacher told him to stop taking his medicine because God wanted to heal him and he needed to show God that he trusted him. So what would you say to someone who had real spiritual reservations about taking medication?
Would you do that if someone told you to stop taking your high blood pressure medicine? I want them to be fair. If you really, really believe that, let's be fair about it. Let's stop taking your blood pressure medicine, your diabetes medicine, your arthritis medicine.
Right.
Let's be complete about it, because if that's true, it applies to everything. Let's not pick psychiatry. To me, as somebody who trained to be an internist and went into psychiatry, I don't see any difference between what my patients are going through with brain disease and if they had arthritis or diabetes. These are all maladies of different organs of the body. The brain is just a different organ. And I'm a cancer survivor. Nobody told me when I had cancer not to take the treatment and to trust God. I had people tell me that maybe I got cancer because I didn't trust God in the first place. But for treatment, they never told me to not, as an act of faith, don't go for the treatment. Don't take the radiation.
No, absolutely. And I think that's a really good point. I mean, and you don't see that in faith communities. You see, what I would refer to as inconsistent theology. Blood pressure medication's okay. That's within God's economy, but psychiatric medication is somehow different. I think, and you certainly probably see this more so even than I do. I think just generally people in our culture are very naive to the brain as an organ.
Yes.
It's like we have like kind of an empty head that has just some kind of a cloud of a mind floating around inside of it. And your brain is really, I taught neuroanatomy for years in graduate programs. And, it's at the end of the day, it's 3 pounds of meat, in your head. I mean, it can be messed up just like your heart or your liver or your kidney. And I think it's interesting how you had your training as an internist and then you went into psychiatry, because you probably have, I would ask you this, I imagine you have a much more of a whole body sense of mental health problems.
Yes, because do you know that your brain can become insulin resistant, pre-diabetic? Wow. I mean, the brain is just like any other organ. You can have circulatory problems, you can have inflammatory problems. The reason these people with COVID get sick is because they get a microinflammation in the brain. The brain has the same issues as everybody else. In fact, the organ, people always compare the brain to the pancreas of diabetes. The brain is way more like the heart, because everything that's bad for the heart is bad for your brain. Everything that's good for your heart is good for your brain. And if your brain is disordered with depression or chronic anxiety, your risk of heart disease, heart attacks, arrhythmias is 3 times that of the general population.
Your brain is the only organ in which, when it's disordered, it has to make the decisions for care.
Yeah.
When your liver is disordered, it's your brain that makes the decisions for care. But when your brain is disordered, your brain has to make the decisions, and they don't always make good decisions.
Right. Yes.
So,
yes.
Michael, in closing, you got people listening that they may have mental health problems. They may have a family member that has a mental health problem. They may be struggling with reconciling that with their faith. How do you give me a few words to give them hope in the context of the treatments that exist out there, or the presence of God within these issues? What do you say to somebody to give them hope?
I tell them to not focus on the problem, focus on the hope, focus on the availability of resources. The people that are listening to your program probably live in communities where they have better access to treatment than most people in this world. And are very blessed in that respect. Go to your OBGYN. Most people start with their OBGYN or their primary care doctor in their journey to try to get help with this. And that's a good place to start in finding out what's going on and who might be a good person to be part of the treatment team. You talked about seeing a therapist. My usual patient, the good treatment teams, as a primary care doctor, psychiatrist, a therapist, and maybe a clergy person, a pastor, some spiritual mentor that's working together to make sure that all aspects are addressed. That's a blessing.
Excellent. Well, thanks for being with us today, Dr. Lyles. It was as good as I would have imagined. You always can very articulately tell us about very difficult things, and people can really understand that. So again, thanks for being with us.
My pleasure.
Thanks so much, Dr. Lyles, and thank you so much, Matt, for being here. For everyone listening, be sure to tune into our next episode where Matt and I are going to be discussing how to cope with anxiety in such a stressful world. And I'm excited to dive deep into that with you, Matt. And as always, I will leave all HHCI information in the show notes. Thank you all again for being here.